Welcome everybody to a talk today by Mr. Andy Williams. He's a consultant knee and sports surgeon, treats professional athletes including Premier League footballers, co-founder of London Musculoskeletal Health Centre is Fortius Clinic, hopefully I pronounced that right, and named in Times 2011 list of Britain's top surgeons. So thank you, Andy, for being with us. Please, could you take it away now?
Fantastic. Well, good evening to everybody. I can't see any of you, so I feel I'm literally in the dark. So I hope my presentation doesn't become too wooden or useless. If there are any problems at all at any point, just shout out. But as you can see, I work in London at Fortius Clinic, which I set up 15 years ago. I was previously at the Chelsea and Westminster NHS Trust, and prior to that, the Royal National Orthopaedic Hospital. And so, but very much London-based, really. Now, I've got a really weird life. For the last 26 years, I've been dealing with Premiership teams. So my first ever team was Chelsea Football Club in 1999. And you can see how old I look. It's almost killed me. But more of that later. So 90% of people come through my door are pro athletes now. So it really is very unusual. And you'd think maybe that means that my practice is not relevant to any other orthopedic doctors, but I would hope I can show you that actually it's very relevant, I think. And I look after a lot of teams. These are just the football teams, 18 of the Premiership on average. And at my peak, I looked after 54 English teams. That's half of the English Football League, which is when it nearly killed me. Plus the rugby teams, quite a few of those, and many other sports as well. And the only way to deal with it really is to say no to the rest of the population. And only about 10% of the people who phone up me just cold calling will actually get an appointment. Now, treating these people, I think, is really important because they ask questions that we have to come up with answers to, and they get simple problems in the general population, but exaggerated beyond all belief. But they also get rare problems for the general population. So I've seen patients who've come and said, look, Andy, I've seen 4 or 5 other knee surgeons. No one knows what's wrong. And because I deal with pro football, I'll say I know exactly what's wrong and we can fix it. And so it's been incredibly educational. It's made me just better and better. And because of the nature of these people, you've just got to get it right first time, which is the GERFT anachronism that's become very popular within orthopedic surgery. There's a real recognition that one of the most pressing problems in modern surgery, particularly orthopedics, is variability of outcome. I mean, it just is crazy. If you go and see one person, you may do very well. You may see another surgeon do very badly. And so we've got to get better at getting it right first time. So this guy on the right, you can see it absolutely testing me. He's doing something I dreamt of. He's a central defender. I used to be one a long time ago. He's 7 months after my ACL, trying his best to break it. So you've got to learn how to do the surgery well and properly and make the right decision making in terms of how to do surgery and also how not to do surgery sometimes. So there are some lessons to learn. Number one, although athletes are special, and they are, when I put a knife into their skin, it's harder than normal people. When I drill their bone, it's harder than normal people, etc., etc. Also, their mental psychology, etc., can be usually more robust than normal people, but not always. It can be the reverse. And they generally do pain really well. But despite their specialness, they still are human beings. And one thing I'm under a lot of pressure from football clubs is to speed up nature. You can't do it. And if you read the newspapers, an ACL reconstruction will keep a player out for 6 months. Well, it's not 6 months. My average time to return to play is 10 months. It's falsely high, to be fair, because many players are ready in April and May and sensibly decide to leave it till the following August. But nonetheless, it's certainly more than 6 months. Also, if somebody's got an injury and the knee is really swollen and angry, if you operate when it's like that, they'll never get all their movement back. So you've got to make them wait sometimes. And you can imagine somebody earning £250,000 a week, there's quite a bit of pressure on me to get on with it. But I will try and explain that by getting on with it, we might actually end up losing time because we get problems. Synovitis, joint lining inflammation and swelling is an absolute nightmare in football particularly, but also all sports, because they just do too much. And I've had a call this afternoon, this sort of mysterious swelling this player has. Well, he's just doing too much. He needs a rest. And so it's sometimes you have to be a bit blunt. Sometimes you have to use something called active rest. It's a concept that I learned from an American surgeon. So if you've got somebody with a knee injury, you might stick them in the gym doing upper body and abdominal exercises just to keep them busy so they feel they're doing something, but keep them off their knee. Another thing I've learned is that natural selection is at work. And if you get a professional athlete as old as 21, then they're probably going to be put together well. There's so many of the youngsters have a minor weakness, if you like, and they will injure themselves on the way up. There's a lot of talk about the huge epidemic, it's often called, incorrectly by the way, of women's ACL ruptures in professional football. And although women are probably predisposed, there's probably less to do with their anatomy being somehow defective. It's amazing. Even female journalists I've spoken to are only interested in why the women's knees are wrong. It's a deeply insulting thing to womankind. But actually, it probably is more of a socio-political problem. The boys get picked up age 6 or 7 years old, and they get funneled into this treadmill of becoming a professional athlete. So they get the best training, the best strength and conditioning, the best of everything. Whereas the poor women join late, they always get second best, and they're not really ripped athletes, if you like, when they get to 18. They're still on the way up and still trying to condition themselves, and yet they're nowadays expected to play as a first team male player twice a week, for example, out of time zones and so forth. And they just haven't had the good fortune of being conditioned to do it. And so I hope, and we have to hope, because unless the women's game attracts either a change in the law where they have to have the same facilities as men, or the TV companies view it as good TV and they make money, I don't think the women will ever get a fair crack of the whip. And the other thing that might happen is a change in the law so that they have to have true equality. So with the boys, the other thing to say is that many boys blow their ACLs when they're on the way up, and you never hear about them because they're youth players. And so actually, I think the difference in terms of ACL rupture rates for men and women is rather less dramatic than the current hysteria is going on about. But basically, I think women need to be given a fair chance and be dealt with fairly from a young age. So going off my hobby horse onto the natural selection thing, these players, as I mentioned earlier, have the best tissues, they have the best mentality, and they can do pain. They're hard as hell. I know footballers roll around a lot, unlike rugby players, but they're only doing that to try and get the ref's attention. If they think they can ride a challenge and score a goal, that's exactly what they'll do. Now, if we have a young footballer, I will fix their ACL. Those are the guys you've never heard of who disappear. They always get back to play and they're happy with their knee, but I've learned that they never get a contract. It's really quite sad, but if the player is under 18 when I fix their knee, the chances are that they will end up never being selected. And the problem is, I used to think it was natural selection, but I think the problem is that because football is organised in year groups up until 18, they just miss a year of football with an ACL. They never catch up their mates. And so it's probably more about their development. Where you've got a first team player, there's often a lot of money invested in that player. Also, they're proven at the highest level. And guess what? Everyone will give them time and they have the ability to make it. Another thing I've learned is about understanding movement and dynamic alignment. Orthopedic surgeons used to be characterized by being not very bright, but things have changed. We have some of the most amazing treatments now and become a very attractive speciality. And we'll be the first to harness things like cell biology and tissue engineering. So I think we're attracting some of the brightest people now, or at least I want to believe that. And I think we have a massive future. Now, ortho in orthopedics means straight, pedos, child. So straight children is the origin of our speciality. And we measure limb alignment on X-ray. And the trouble is, it's a static examination. And one thing I noticed was that if a patient tears their lateral meniscus, the outer meniscus, and it's trimmed up and tidied up, the outcomes are awful. They get arthritis within months, and they do really badly. Now, if you look at this photograph of this glorious team winning the Premiership, when I was lucky enough to be on the pitch, their legs all lined up, but in a bowed position. Technical term being varus. So they're all varus aligned, which puts pressure on the inner side, the medial side of the knee, and yet lateral meniscectomy is a disaster. So how could that possibly be? Well, if you go to a game and you get up close, you'll see that when they're running and being twisted inside out, they spend a lot of time with a knee in a dynamic valgus and knock-knee positions. They go from bowed leg to knock-knee very rapidly, and so they can't hide the problem with the lateral meniscus, even though they're naturally lined up with bowed legs. That bowing, that varus, makes them faster, so they're sprinters. In rugby, the really tall guys who move around pretty slowly, they actually have the opposite, valgus knees. It's something about that makes them good at jump land, for example. So what I've learned is to appreciate dynamic loading, which is so different from static loading and not greatly appreciated by most branches of orthopedics. And what about getting to see these people? Well, you've got to realize and show empathy that you understand there's a lot of pressure on them. Although footballers can earn an enormous amount of money, the average wage in the Premier League is about £80,000 a week, for example, all they want to do is play football, and they would do it for nothing, as they did in the 60s and 70s. They are frightened because they worry they might lose their place in the team. They often have deadlines. One of the first questions I'll ask a player is, how much longer do you have on your contract? So if somebody blows their ACL now in September and their contract's up at the end of the season, we've got a pretty tough job to do. So there's always something on their mind, some pressure. Also, I need to behave in a different way. The players are special, they need a special consultation. And the first thing is I got to be really confident. I never do bullshit or lie, but I am confident. I'm confident based on my experience, my learning, often self-learning, and application of some knowledge. What I would never do is tell a lie, and you have to be absolutely honest, but how you word those things is very, very critical. Now, I may be running late in clinic and have people lined up outside, but you have to take time. You have to answer all of the questions. You take the player through it. You're usually going to have a doctor and or physio with the player, often an agent if they're a big name player, and family as well. We have a sofa in my clinic, believe it or not, where they all sit slightly out of the way. It's good for me, and I can give all my attention to the player. You've got to let them know not just about the contract, but that you appreciate this is a really serious business. And it isn't just a financial business, but for them, it's everything in their life. And all they want to do, as I said earlier, is to play. Now, when you deal with complicated situations, and that doesn't necessarily mean difficult knee problems, it might mean the setup of the room with the player, the agent, all these pressures on you. It's quite simple. You don't have to do anything complicated. You just have to be thorough. You take a proper history, you examine the knee properly, you get the right investigations, x-rays, MRI scans, etc. And then you go and make a sensible decision based on that information. It's essential that the whole of the players' medical team is involved. Communication is one of the biggest things. Everybody has to know all of the time what the plan is. Otherwise, you get back chat, uncertainty. The player can smell it and they start to lose faith. And one of the things I talk about a lot is creating the faith. As I go at the top of this slide, there has to be an atmosphere that creates the feeling that that player doesn't want to be anywhere else on this planet to see me. And the same goes for the operating theatre if having surgery. I have to worry a lot. And if a player's got persistent swelling, like the lad I mentioned earlier on, who's doing too much, we'll still get that knee scanned in case they're developing some joint surface damage. If you load a knee with swelling in it, the joint surface breaks down. And so you need to keep checking. In terms of giving bad news, if you have a player with a really devastating injury, of course it may be career ending. But the way you put that over to the player is essential. You mustn't hide from it. And so a player with a dislocated knee, not a dislocated kneecap, a dislocated knee, 3 out of the 4 ligaments gone, I will say, look, this is a really serious injury. and it's quite possible that it will be a career-ending one. However, I've dealt with this sort of thing before, and it's not over yet, and I'm used to winning. And so by creating that positivity, you need that player to know the bad news, but to have a positive upside, because they've got to come on a pretty tough journey in terms of the rehab, etc. And if they're negative from the word go, it's going to be terrible for them as well as everybody else. Now, when it comes to deciding on treatment, it's very, very important to realize that in professional sports surgery, actually most treatment is non-surgical. And so the vast majority of my appointments don't end up with surgery anymore. In the good old days, when I probably did 50% athletes, I would see many, many well-off London skiers, and they would come to me because they wanted an operation. They'd seen somebody else, and my life was full of surgery. Whereas now, most of my conclusions are non-surgical treatments. And what the player and the medical team need is a plan with time frames. And no one ever teaches you this at medical school or even when you're training in orthopedics. And so I feel very much like I've been riding a surfboard since 1999. I'm sort of expecting and perhaps waiting to fall off at some point. But needless to say, having had that big experience, I've learned how long it takes to get back after various injuries, etc., etc. And so I can be pretty accurate, really, and give a lot of confidence. Now, when you have to do an operation in professional sport, you have to choose the smallest you can do and get away with, because the bigger the surgery, the bigger the trauma to the knee, the bigger the interference with natural joint position sense, so-called proprioception. And so if you do the big operation that you might do on the general population, an athlete may never quite get back that special thing that made them special, the speed, their ability to do things quickly. So if you had somebody with a malalignment of a limb, in the general population, you often straighten the limb out when you're doing the ACL, for example. If you do that in a pro athlete, they probably won't get back from it. And you've got to remember that all that matters is performance. I'd rather do something small that perhaps doesn't do the job, and we can always come back and do the bigger thing later. So here's a couple dramatic examples. Both these guys had major injuries to their knees. They blew out both cruciate ligaments and the medial collateral ligament. Now, the guy on the left in the green jersey was treated by somebody else in London, and he very kindly told me what he did. And so when the guy on the right rocked up in my clinic, I knew the answer. And rather than diving in straight away and fixing heroically all the ligaments, causing a lot more trauma, which is guaranteed to give you problems such as loss of range of motion, I did exactly what John Hollingdale did. I braced the knee. PCL injuries will often heal by themselves, MCL the same. And then once everything had healed up, I was able to deal with the one thing that doesn't heal, and that's the ACL. I did a reconstruction a couple of months later, and both these guys did extraordinarily well. Now, this is another example, similar sort of problem, a bit more severe. And you'll see this athlete's very kindly allowed me to show this video. It's on the internet, in fact. She has a bad landing, you can see. Now, she's involved in this rather unusual trampoline gymnastics. There's quite a risk to the knee when they land. You can see here it all goes wrong, and the right knee buckles inwards. And obviously a very serious injury occurred. She managed to fracture the lateral femoral condyle, so you can see that here in the photograph. She also had injuries to all four ligaments. Grade 3 means it's complete, so she had a grade 3 of the ACL. The posterior cruciate ligament was grade 2, which is not quite so bad. There was pulling off, avulsion means pulling off, of the lateral collateral ligament and the popliteus tendon. In orthopedic jargon, we call that the posterolateral corner, PLC. And she had torn both the menisci, and the medial collateral ligament was a severe tear as well. So what did I do? Well, I wanted to do the smallest operation. So first up, I fixed that fracture back. As you can see, I've opened the joint to pin it back in place. I repaired both the menisci, and I stitched the lateral collateral ligament, the popliteus tendon back. So that dealt with the postlateral corner, so-called, the fracture and the meniscus tears. I then braced the knee, remembering this guy here, and got the MCL and the PCL to heal. And so at 8 weeks after all that, I got rid of the brace and we went to surgery and did a reconstruction of the ACL. Now, normally to do that, I borrowed tendon from elsewhere in the body, such as hamstrings or the patellar tendon at the front of the knee. But for an elite athlete, as she wasn't just a trampolinist, and I didn't tell you that. She was also the world champion of 100 and 200 meters sprinting when she was 16 years of age at the Student Games. And we all thought she was going to win a gold medal at Beijing. Now, obviously, that was not the case. But rather than use her tissue, I used some donated tissue, allograft. She's a straight line runner. She doesn't need as much strength in the graft as some. And that's what we did. And you can see 5 years later, she got to the semi-final of European Championships. And since then has been remarkable. She's still 8 years on. Sorry, 20. I can't do the maths. I apologize. I'll let you do the maths, guys. 18 years on. She's still a professional athlete. She's won bronze medals in the 4x100 team twice and silvers in the World Championships. So all in all, a really good outcome. And I'm very, very grateful to the teaching I got from the people ahead of me. So this approach has worked very well. Now, as well as the surgery, you have to understand that we need to have a really good team around us, MDT, a multidisciplinary team. So I'm really keen on engaging with the physios, the sports physicians, etc. And these guys are often really are the people who make me look good. The trouble is sometimes they can make me look very bad. And so I'm not going to relax and just hand over to them without getting involved. It's very, very important that we respect the skills of those other people and engage with them, communicate with them properly. And I've had to learn about rehab. I've never taught about it at medical school, nor as a registrar, which is crazy because understanding of the role of muscle in terms of providing shock absorbency and stability as well as performance is just never appreciated when you're at a junior level. And good muscle will stabilize an unstable joint. It'll shock absorb a damaged joint. And so it's very, very important to understand the value of rehabilitation. And it's such a tragedy it's not taught to us. Now, I was a bit surprised when I started out that the physio team would ask me about the physio. And obviously I knew I wasn't trained in it. But I think the reason they often do is that they want to plan. And it's partly because they're under so much pressure from the coaches, etc. They go in every morning, get told off. And they like to be able to say, well, Andy said this. And so me giving them a plan is a key thing. And obviously, as I said earlier on, it's important for me to stop some of the crazy stuff that goes on in pro sport. Although most people are brilliant, there are one or two guys who do genuinely make me look bad. And the other thing is, despite the pressure to give the answers everybody wants, you've got to go long. If you start to suggest that the player will be back before they can be, you're going to head for trouble. So we mentioned that I wasn't taught anything about rehab, but for everybody in my business, it's important because the general population could do with more and better physiotherapy, and it would stop a lot of unnecessary surgery. And the key is to understand that neuromuscular control gives shock absorbency and stability as well as the performance, as I said. Now, another wonderful thing for me has been the ability to do clinical research. These patients really test me and the operations I do, and so they differentiate treatments. So often you read papers about different treatment options, and the conclusion is this operation is not inferior to another one. I mean, that's just hopeless. It doesn't tell me what I want to know. I want to know which is best. With athletes, you certainly find out which is best because they will test you to the limit. And in general population, many options: hamstring, patellar tendon, quadriceps tendon, even allograft for ACL reconstruction works and works well. But in these guys, allograft, disaster. It's just not strong enough. That sprinter was a straight line runner, didn't change direction. We got away with it. And so it was a calculated decision. Also, to help your research, you get about 100% follow-up. And we lose one or two cases in cohorts of several hundred. And so for big outcomes, like for an ACL, the graft re-rupture rate, or learning about return to play times, you will have 100% follow-up or thereabouts. What they'll never do is fill out a patient-reported outcome measure form. And whereas the general population might, but the trouble is you only pick up, even in the best trials, maybe 75% of your population. And so being able to have access to this amazing population of people, I think has been fantastic for me. I've learned so much. So we mentioned that they get common injuries. And so meniscal lesions we mentioned earlier on, for a professional footballer, loss of any lateral meniscus function is a disaster. And so I try and repair those meniscal tears, doesn't matter how bad they look. And I've also learned that medial meniscal repairs fail in athletes unless you're doing an ACL reconstruction at the same time. And so if somebody comes even with a big medial meniscus tear, if it's on its own, there's no other ligament problem, then I'll take it out, actually, because the consequence of it as well is actually relatively minor compared to the consequence of losing the lateral meniscus. We've also learned that the way you do the surgery is very important. The types of repairs I've called all inside. They're little devices that can be put in through a couple of keyholes. Everyone loves them because there's no extra scar, you don't do any dissection. But their failure rate is unacceptable. And I've gone back to old-fashioned so-called in-out suturing. During this, I make a peripheral wound and I repair the meniscus with really long needles connected by a suture. And those long needles emerge around the knee, and I pull out the suture, tie those sutures over the capsule of the joint. And the results, certainly for the medial meniscus, are far better with the old-fashioned technique at 28 pounds a suture compared to between 250 and 350 pounds a suture. So massive healthcare economic impact of learning about this. But the problem is that most of the surgeons find the all inside easier, quicker, and no one can be bothered to change. But it would save the NHS a hell of a lot of money if surgeons were made to learn the old technique. And we've written this up on a couple of our papers. So what about ACL reconstructions? If we do that in detail, that's one of the hot topics in the newspapers at the moment. I had a big series here of adding an extra articular tenodesis. So what's that? Well, when I do an ACL reconstruction, I basically pull some tissue into the middle of the knee where the old ACL was. Trying to stitch the ends together doesn't work very well, although there is a bit of interest in it at the moment. So I replace the ACL, but when the ACL breaks, the periphery of the joint is stretched. The lateral side of the knee almost dislocates to allow the ACL to break. And so by tightening up the lateral soft tissues, the iliotibial band, for example, I can leave it attached, a strip of it attached to the tibia, and then bolt it onto the lateral femur. I've basically got myself a second ACL. It's a oblique structure on the lateral side of the knee that stops the tibia going forward, and that takes some of the stress off the ACL. And in a big group of professional athletes, 455, we showed that those without a tenodesis had a 9.5% ACL re-rupture rate. Those with, it went down to 3.4%. And so, we'd never have learned this without dealing with athletes. And adding a tenodesis to at-risk people from the general population is also very valuable. And so all kids need to have it. Kids who blow their ACLs have often got something wrong with their knees, and they benefit from that extra surgery. But I've also looked at, in football, the effect of which graft you use. So the black columns on this graph are hamstring tendon. The grey ones are patellar tendon, and also looked at where we place the graft in the femur. And there's something called the AM bundle position, which is deeper in, and there's something which should never have been called the anatomic position, but it has been, and that's the center of the so-called footprint, where the ACL joins the bone. If you imagine a footprint, it's in the middle of that. And if you put the graft, the patellar tendon graft, in the AM bundle position, the AMB position, there's a 7.5% re-rupture rate if you don't use a tenodesis. Hamstrings, it's 10%. But if you go to the left, I stupidly moved my graft because some experts in the field thought it was a good thing to go to the center of the footprint. My re-rupture rate almost doubled for hamstrings. It went up to 18%. But on the right-hand side of the graft, we've worked out what to do. So professional football, if I use a patellar tendon graft with a tenodesis and I put the graft in the AM bundle position, my re-rupture rate is only 2%. And unfortunately, the black column had only 4 cases, so we can't really draw any conclusion on that with hamstrings. But it's been a wonderful privilege to be able to learn how to do the operation properly, and then we can hand that on to the rest of the population. What about the rare injuries? Well, we mentioned this happens sometimes, and the medial collateral ligament is in various layers, and there's a deep portion of it. And over the years, I kept noticing these cases that came up to me, and it's always with football, and they didn't come with instability. There was no slack in the ligament really, and they presented with pain that just wouldn't get better. And by investigating it further, we found out there was an injury to the deep MCL that failed to heal. A bit like a bone doesn't always join up, so this ligament didn't heal up. Imagine if you have a split lip, every time you smile, it cracks open again. And they just do too much too soon. It doesn't settle down. So that's all the good news. There is some bad news, unfortunately, and not everybody in football is nice. I've been sued once, and I would please ask you not to Google it and not to click on the story, because the fact I won the case is on page 4, whereas the fact that I was being sued is on page 1, unfortunately. So please, in respect of me spending an hour this evening chatting, please don't click on any of those links. I'll be very grateful. Find the one where I won and you click on that. That'll help bring it up to the front. So very, very unpleasant to be sued, and very stressful because it was an ex-Premiership footballer. It got in the newspapers. I think possibly the opposite side were trying to make me settle out of court, which I wouldn't, because I've done nothing wrong. But the silver lining is the picture. I don't know where they got this picture of me, but I think I'm probably about 25 years old. And look rather dashing, I thought. Anyway, so being sued is not nice, but you can protect yourself by practicing to the highest standards, documenting everything thoroughly. And there are a few other important things. You have to be medically minded, unfortunately, in this business. But there are also many, many other problems. The non-medical medical expert is a classic. So the coach at the club saying, well, when I had my ACL, I was back at 5 months. Well, no, you weren't. And there's all this false memory of how quick it is and so forth. When there's money and glamour, you attract gurus, and some of those are good, but some gurus are crazy. I wish I could tell you the stories. I can't. But some of those treatments actually harm the players, or at least delay treatment, good treatment. Also, you have to be very careful with surgeons offering unrealistic timescales. There are 1 or 2 shockers out there who always tell the player it will be 6 months for an ACL. And so they catch the fish, do the surgery, and it's never 6 months, I can tell you. And unfortunately, even amongst the medical staff, other surgeons, club doctors, physios, etc., sometimes there is a bit of dishonesty. There's certainly a lot of jealousy, and there's no loyalty at all. You're only as good as your last case, and if you have one that goes badly, it means you're bad as well, even if you've given 20 years service to that club. So, talking about medical legal cases, I was the expert witness on this case. You're looking at on the left, a sagittal view, so a side view of the center of the knee, and you can see a drill hole and a screw at the top. Now, be mindful that this was actually a PCL reconstruction. PCL attaches here, so this drill hole should have been back here. This is almost like an ACL tunnel. It's nowhere near where it needed to be. The case didn't go to court because of this. In fact, on the right is the reason, and the drill hole in the femur actually exploded the femoral condyle. And this case went to court, and the Medical Protection Society decided because of this case they would no longer insure surgeons dealing with professional athletes. It was pretty shocking, but you can see why. This case on a player who was actually in the Championship, he'd never played Premiership football. He was 25 already, and my son, who played Championship manager, didn't know his name, so therefore he couldn't have been that good. Wanted £8.5 million, and at that time our maximum coverage was £10 million. And so the MPS panicked. They also realized that the surgeon could be sued not just by the player, but by the agent, the club, and the sponsor even. Anybody who had anything to gain out of this player could sue for damages. So it makes it very, very high risk. And not surprisingly, I do think about being sued a lot. Also, the service that's expected is extraordinary. The expectations rise and rise. I am literally on call 24 hours a day. My office is really well organized to deal with these people, and I have to be able to offer a patient an appointment within a day. If I can't do that, I'm not at the races. And then when it comes to treatment or decision making, even if I'm not going to do surgery, you've got one chance to get it right. And as I mentioned, you're only as good as your last case. So you've got to get it right the first time. The most important way of becoming excellent at what you do is about attention to detail. So these guys are going to test me. I've got to be absolutely up to date. I've embarked on a never-ending life of learning and research. And then when you come to have major decision, you need to use investigations properly to help that. But if you're going to execute an operation, you have to nail it first time. And so I do a lot of planning. I do a lot of thinking. Our appointment times are quite long, so I make less mistakes in clinic. And I do a lot of worrying, which sometimes can be a bit too much and be damaging. And about 2 or 3 years before COVID, when I was looking after 54 clubs, I did have to have a bit of a lie down for a couple of years. Basically, I was absolutely exhausted. I was worn right down to the bootstraps, and I'd had my default was worry. But as I told a little fib about giving up football, and I went from 54 clubs to 6, and then the next season 9, then we had COVID, and I decided I'd get back into it, but I've done it in a much better way this time around. And it's certainly helped stop the worrying to a degree. But why do I stick it? Because there are all these negatives. Well, first of all, it's fascinating. It really is. It's extraordinary. And it drives you to make yourself better. And you can hand that on to your normal patients. Now, although nowadays that's only 10% of my patients, I teach a lot. And so the surgeons should be better for their patients. And of course, in the past, I saw a lot of normal people. You've got to realize that everyone's nice, but you also need to realize that you chose to do it. In this case, me, I chose to do it, and I could stop doing it. I'd done it once before when I had to. I was in a bit of trouble. And so actually, there's no one compelling me to do this. And it's very reassuring when you realize that and remember it. You need to be brave at times. And sometimes there's stuff that comes through the door you've never seen before. I've never seen before. No one's ever seen before. And so I've got to be very brave and handle it. I've got to be robust, must resist the pressure to do what the team wants, which may or may not be good for the player. I've got to be incredibly patient. I mean, I can be exhausted driving home at 8 p.m., which is my usual sort of finish time. And I'm on the phone to people just driving me crazy. And, you just got to suck it up if you want to be in this business. And one of the things I've learned, which is true of all doctors, actually, the really great doctors, of course, they're all knowledgeable, they're experienced, they're good at what they do, but they have charisma. And don't forget that a lack of charisma is fatal. I was sitting on a toilet in Chicago and someone had that paint up on the wall, the door facing me. And I thought, what a great line. And having that ability to smile, engage with the player, they have various levels of intelligence, background, etc., and making them feel at home is a critical thing. And probably most important, have an unbelievably tolerant spouse. And I'm very, very lucky with that regard. The conclusion, I would say, doing high-level sport in high volume is a never-ending source of learning for me. It's made me better and better. The questions they ask will lead to solutions. And I showed you that graph of how we reduce the risk of ACL graft failure. And that's fantastic. A 2% re-rupture rate in pro sport is extraordinary. And that's simply the product of study, research, etc. And I promise you that sports surgery is good for the general population. Thank you very much indeed. These are some disclosures. I sit on a number of boards for orthopedic organizations and journals, but I do have a financial interest in a little company that makes orthopedic screws. After 5 years, I've still not made a penny, so it's not that worthwhile. And I do receive sponsorship from Smith & Nephew for my research, in part, not all of it, and they partly fund somebody working with me. So thanks very much indeed.